So what we are going to look at today is Chapter 6, Justice and the Allocation of Resources. This chapter covers formal and material justice, the micro and macro allocation of healthcare, theories of justice, and then American healthcare today. So first we want to think about, what does justice mean in the context of healthcare? Are our healthcare services and costs equally distributed in the United States? Is our system fair? That are kind of the big questions we're looking at as we read this chapter. So first, we want to look at formal and material justice. Formal justice is a theory thought to be kind of initiated with Aristotle. And it says that equals must be treated equally and unequals must be treated unequally. In order to have formal justice, categories need to be created in order to apply that. So what does equal mean? How are we measuring that? So that takes us to material justice, when we use a relevant characteristic or criteria to determine treatment. So for example, we might decide that all children are provided free health care in the U.S. because they are not old enough to work and pay for it on their own. That would be an example of that category that we would use in formal justice, would be children. Now we go on to micro and macro allocation of healthcare. Macro, which means big, refers to how a country or other large entity uses its healthcare resources. So for example, if Congress decides to increase spending on cancer research and decrease spending on Alzheimer's research, that would be an example of the macro allocation of healthcare. How as a country are we spending our money? Another example might be when Congress decides what tests, vaccines, and exams will be required to be covered by health insurance companies. Micro allocation, micro means small, and so it refers to small-scale decisions about how to distribute resources when they are limited. So for an example, maybe there's a pharmacy that has 1,000 doses of a vaccine for a new deadly disease. How does the pharmacy decide who to give the vaccine to among the 5,000 people that live in the town? So in thinking about macro allocation, a two-tier system would be the idea that we could have a healthcare system where everyone is guaranteed a basic level of coverage for preventative services and catastrophic care. And then there would be a second tier, would be care that you would have to pay for, and it might take place at a private facility, might have more amenities. So this is the idea of a two-tier system, and with it we would have a decent minimum. It would guarantee that everyone gets basic coverage. So again, this is an example of macro allocation of healthcare. When we look at macro allocation, there are some issues to be thought about. One is, what services should be covered and who should decide. Should it be the government that decides? Should it be a citizen panel? Should it be a group of physicians? How do we contain the budget? We know that spending on healthcare is huge in the United States, so how do we decide what we're going to spend money on and what we're not going to spend money on? And then also, how do we ensure equal access? We know that, for example, when we look at Medicare patients, and those are patients over the age of 65 who are on government health insurance, that African American patients receive fewer procedures and diagnostic tests than white patients. So how do we make sure that that does not happen? Microallocation, this is when we look at decisions with individual patients. One kind of way to think about this is lifeboat ethics. This term has been used to describe how rich nations deal with poorer nations. So for example, if there is an outbreak, let's say the COVID epidemic, how did richer nations choose which poorer nations to provide vaccines to? This is an example of when, you have to think about who are you going to save from drowning. And it is a tough decision to make. Another way to pursue microallocation of resources is through the process of triage. And this is certainly something that happens in emergency rooms and on battlefields. And this is when we divide the sick into three groups: the walking wounded, the fatally wounded, and the serious wounded. The walking wounded are people who are just a little bit wounded, and so they are going to be put to the side at the beginning. Fatally wounded are people that we know are going to die, and so for them we give just basic kind of palliative care to decrease their pain and make sure they're as comfortable as possible. Most of our resources go to the third group, which is the seriously wounded. Those are those that we don't necessarily know they're going to die, but they need care because they have been seriously hurt in the situation. So when we are looking at a big group of people and there's an emergency, whether it's a natural disaster like a hurricane or whether it's in war, we often use this triage process. Now, what about within a hospital? There are several options to use if you are faced with multiple patients and you need to decide who is going to get the resources. So one option would be medical utility, and this is looking at who has the best prognosis, who is most likely to survive. Medical utility states that we should give that patient the greatest share of resources. So find the patient who's most likely to survive and treat that patient first. Social utility looks at which patient has the greatest social worth. So, for example, in the case in the book, they talk about the President of the United States, saying that the President of the United States has a great social worth, and so that person will receive the greatest share of our resources. The third option would be first come, first served, and this is just we treat each patient based on when they arrived. Now, there are problems with each of these ways of addressing who gets the care first. In medical utility, what if the prognosis is wrong? What if we assume that someone is not going to make it, but in fact they could survive if they were given treatment? For social utility, we really worry about prejudice, because how do we decide if someone is more worthy than another person? Is a teacher more or less worthy than a police officer, more or less worthy than a nurse, more or less worthy than a child? How do we make that decision? And, there are many ways it can be prejudice based on sex, age, race, and other biases. First come, first serve, the problem is someone might die because they are waiting, and we might have been able to save them if we had treated them first. So all of these ways of allocating resources in the micro setting, so in a small setting, they all come with, their own problems. Now we're on to theories of justice, and the book kind of breaks it up into three major theories: egalitarian, which is equal access; utilitarian, which is the greatest good for the greatest number; and libertarian, which have to do with personal rights and social and economic freedom. And let's talk a little bit more about each of these. So egalitarian theorists would argue that in a rich country like the United States, we should be able to provide everyone with universal health care. And there are two theorists that the textbook mentioned that are important in this area. One is John Rawls, and he came up with the contract theory. He argued that society only works because we have agreed to work together to advance the good of all those in society. So in that case, we should, provide equal access to things like healthcare because we're all members of society and we all contribute. Norman Daniels goes further by asking us to think about society as a whole. So what is best for all of us together? And he argued that when thinking about that, we should imagine what we would do for our own life and apply that to society. So if we would want in our own life to get a heart transplant, if we needed a heart transplant, then we would apply that to society. Utilitarian theories, these theorists believe we should strive to create a society that provides the most benefits for the most people. And sometimes they use QALYs, which are quality adjusted life years, when trying to determine the cost benefit of a particular procedure. So for example, if we're thinking about that heart transplant, they would think, well, how many healthy years would someone get out of this heart transplant versus the cost of the transplant? And one QALY is equal to 1 year of perfect health. So if someone is in less than perfect health, their year would equal less than 1. And the problem with this is that people who have disabilities, it's considered that their years are less than perfect, and so a year of their life would be equal to less than 1. That really presents a problem when it comes to equity, because we are treating people with disabilities as if they're literally that the years of their life mean less than someone who does not have a disability. Libertarian theories, these theorists really focus on individual freedom. They aren't concerned about fairness, just choice. In the US, we really have a free market system where people who can afford to pay more will get better health care. And so the libertarians would argue this is good because it's based on individual choice and preference. But there is no guarantee of even a basic level of health care in this system. So libertarians are really focused on freedom, not fairness or justice. Looking at the American healthcare system today, in spending, we spend more per person than any other country in the world. There's a typo there. It should be $9,255. I've got an extra 5. We don't have the best outcomes, though. Even though we pay the most in healthcare, we don't get the best results compared to other countries. This is a look at other world healthcare models. So what do other countries do? So in Great Britain, Spain, Italy, and Hong Kong, healthcare is paid for by the government through the taxes. There are no medical bills. Hospitals and doctors are employed or paid by the government, and costs are controlled through rationing, which means that the government decides what services are available and what services are not available. The Bismarck model, which is in Germany, France, Belgium, Japan, and Switzerland, healthcare is paid for by nonprofit health plans called sickness funds that are financed by employers and employees, and the costs are regulated by the government. There's also the national health insurance model, which is in Canada, Australia, Taiwan, and South Korea. Here, providers are private businesses, so doctors and hospitals are private employees, but the payer is a government-run insurance plan that everyone pays into, and costs are controlled through rationing and the lack of a need to make a profit. Because the government is providing health insurance and the government is not making a profit on that. The last one is the out-of-pocket model, and that's India, China, and some of South America. Here, there is no provided health insurance, so those that can afford to get health care do, and everyone else does not. In 2003, the Patient Protection and Affordable Care Act was passed. It is commonly referred to as Obamacare. It did put into place a lot of things that were able to provide more access to health care for more Americans. It did require all Americans to purchase health insurance. It expanded Medicaid, which is government-funded health insurance for those in poverty. It established health insurance exchanges to make health insurance more affordable, provided subsidies for low-income Americans, which means that the government will help you pay for health insurance if you have a low income. It stopped insurance companies from dropping customers when they got sick and for denying coverage for pre-existing conditions, and permitted kids to stay on their parents' plans until they were 26. It also was funded through fees and taxes on drug makers and other health industry companies. And then finally is the quality improvement movement. In 1993, there was a study done that showed that there were 98,000 deaths each year due to medical errors in the U.S. Since that report, doctors and hospitals have really looked at how can they improve quality and make sure people don't die due to medical errors. And so that has been a success. Something as simple as having physicians enter orders by computer instead of by hand reduced medication errors by 81%. Training reduced adverse outcomes for preterm deliveries by 50%, and the creation of rapid response teams resulted in a 15% decrease in cardiac arrest. So we can improve our quality of healthcare when we set out to do that. I hope this helps you kind of get an idea of Chapter 6. Make sure to carefully read the chapter and all the other resources provided, and let me know if you have any questions.